So I will start with the axillary lymph nodes. Remember, there are 5 groups of axillary lymph nodes, and they drain the upper limb of that side, breast, thoracic wall, and the upper part of the abdominal wall. The groups are, if you name the groups, you have an anterior group, which is also called pectoral group because it is in relation to the pectoralis minor muscle, and a posterior group, a posterior group, a posterior group, which is also called subscapular group because that is in relation to the subscapularis muscle. Then you have a lateral group, which is in relation to the upper end of the humerus, so arm. Then there is a central group which drains all 3 previous groups that I mentioned, anterior, posterior, and lateral groups. And then finally there is an apical group into which all the lymph will ultimately drain into. And from there it will drain into the supraclavicular nodes, which are cervical group of nodes, and from there into the right lymphatic duct or the thoracic duct and into the bloodstream. So that is how they drain. So if you draw the drainage of lymph into lymph nodes, I found this diagram from internet. It's a very good diagram that gives a summary of all areas of lymph drainage. So not only axillary, even inguinal, and even other areas, anterior and posterior. So you can see our issue is this one. Okay, so this is the area of drainage of axillary lymph nodes. You can see above the umbilical level, it can go into the axillary nodes. That is the upper part of the abdominal wall. So then further about the axillary nodes. So in a diagrammatic way, if we represent the axillary lymph nodes, this is how you see them. If you draw the axilla as a triangle here, rather a pyramid, the apex of the apical nodes are at the apex of the axilla, bounded by the first rib, the superior border of the scapula, and the posterior surface of the clavicle. So there you get the apical nodes. Then you get the anterior or pectoral group and the posterior or subscapular groups, as I mentioned before. Then the other point is that these nodes, the anterior nodes, are along the lateral thoracic artery, and the posterior subscapular group is along the subscapular artery, and the lateral group is along the axillary vein. And here also you can see that from the apical nodes they go into supraclavicular nodes, and from there into the right lymphatic duct, or directly from the apical nodes they can go into the right lymphatic duct if it is the right side, and if it is the left side they will go into the thoracic duct. So that is the basic arrangement of axillary nodes. When it comes to the lymph drainage of the upper limb, the superficial parts of the upper limb, if you divide them into ulnar side and radial side, the superficial lymph I am referring to, from the ulnar side of the hand and forearm. So if you draw the hand and forearm here, that lymph will drain into, from the ulnar side, will drain into the supratrochlear group of lymph nodes at the elbow region. Then from the radial side, so this one actually drains along the basilic vein, the ulnar side. Then superficial lymph from the radial side of the hand and forearm will drain along the cephalic vein, that side, drain along the cephalic vein into the lateral group or infraclavicular group of lymph nodes. Lateral or infraclavicular groups of lymph nodes. Now this infraclavicular group, it's not an axillary group of lymph nodes. That is outside the clavipectoral fascia. If you remember, you get clavipectoral fascia here below the clavicle. So superficial to the clavipectoral fascia, you get infraclavicular lymph nodes, and deep to clavipectoral fascia, you get the apical group of axillary lymph nodes. So whatever that lymph goes into the infraclavicular group will, through the clavipectoral fascia, they will drain into the apical nodes again. Or some can actually go into the, I think, supraclavicular groups also. So then this is about the superficial lymph. Then all deep lymph from the upper limb, that is, hand, forearm, arm, all deep lymph, plus whatever that drained into supratrochlear group will ultimately drain into the lateral group of axillary lymph nodes. So they will ultimately, all deep lymph and the lymph from the supratrochlear will go into the lateral group. Then from there into the central group and apical group. Okay, usual way. That's how the lymph drainage of the upper lip takes place. So if you happen to remove axillary nodes, axillary clearance during breast surgery, breast mastectomy or something, and then you will get obstruction to lymph flow, that I think. Then few things about this cervical rib. Now the cervical rib is an accessory rib attached to the 7th cervical vertebra, as you can see here, 7th cervical vertebra, and very commonly there is a fibrous band attached from the tip of the cervical rib to the usual first rib, the normal first rib. And it is this band that gives rise to problems in cervical rib, because this band can actually compress the this is T1 root T1 root. It can compress T1 root of brachial plexus, giving rise to pain, numbness, paresthesia of the T1 distribution of the upper limb, that is the medial aspect of the lower part of the hand, forearm, and the hand, forearm, and the lower part of the arm. So that is actually one cause of thoracic outlet syndrome. You know what is thoracic outlet? So this area forms the thoracic outlet or inlet, whatever you call it. Compartment of the right arm. The right arm, if you take the humerus, if this is your humerus, and outside you get the deep fascia encircling the arm. There are two intermuscular septa, a lateral one and a medial one, connecting the deep fascia to the periosteum of the bone. So it's a very firm attachment. Actually, some authors describe it as continuation. Intermuscular septa continue inside as the periosteum and outside as the deep fascia. So it's a very finely closed space. That's why if you increase the pressure in this space, you give rise to compartment syndrome. So then, so there is in the arm there is a lateral intermuscular septum and a medial intermuscular septum, dividing the arm into an anterior compartment and a posterior compartment. In the anterior compartment, there are three muscles: coracobrachialis muscle, biceps brachii muscle, and brachialis muscle. And all these, all three muscles are supplied by the musculocutaneous nerve. A branch from the lateral cord of brachial plexus, and the segments supplying these muscles are from C5 to C7. Now 5 and 6 mainly for the biceps and brachialis, and C7 actually is almost totally given to coracobrachialis muscle. Then the posterior compartment, there is only one muscle. Which is the triceps, which has three heads: the long head, lateral head, and medial head. Radial nerve supplies the triceps muscle with C7 and C8 segments. So there are other issues with the radial nerve supply with branches and everything we will discuss while we develop the lecture. Then a few things about the musculocutaneous nerve. Now, out of the four main nerves that supply the upper limb, which are the musculocutaneous nerve, radial nerve, ulnar nerve, and median nerve. So this is the first one that is given from the lateral cord. As I said before, C5 to C7 segments are carried in the musculocutaneous nerve. You remember it as the first three segments of the brachial plexus. And in the axilla, it supplies the coracobrachialis muscle. So that is the first muscle to be supplied by the musculocutaneous nerve. Then in the arm, it supplies the biceps and brachialis muscles. Now remember, brachialis, its larger, greater part of the brachialis is supplied by the musculocutaneous nerve. It's mentioned here. This is from Richard Snell. Okay, remember the book. It's a very nice diagram. That's why I took it. So it's the greater part of the brachialis is supplied by the musculocutaneous nerve. But for MCQs, you remember the brachialis is also supplied by the radial nerve. I'll show you in one of the slides that I have in this lecture. Then the important thing is the musculocutaneous nerve. I think there's a diagram. Yeah, the musculocutaneous nerve. After supplying the muscle, the motor parts to the muscles here in the anterior compartment, its cutaneous part, it's a musculocutaneous, this cutaneous part leaves the anterior compartment and enters as the lateral cutaneous nerve of the forearm, just lateral to the biceps tendon in the cubital fossa. So it goes through the cubital fossa before it comes into the superficial fascia of the forearm, and it becomes the lateral cutaneous nerve of the forearm, and it supplies this lateral side of the forearm. So it is the musculocutaneous nerve that supplies that area. Remember that point. So then when it comes to the hand, it is a different nerve, a branch from the radial nerve, superficial branch of the radial nerve. We'll come back to it later. Then if you take a cross section of the arm, you will see these muscles in cross section. The coracobrachialis is not seen because this is some mid-arm section. It's more proximal. Coracobrachialis is more proximal. So you see in this one, you see the biceps brachia and brachialis muscles. And in between the muscles, sandwiched between the two muscles, you have the musculocutaneous nerve. Okay, so if you lift the biceps brachii, you can nicely see the musculocutaneous nerve between the two muscles, and at that point the nerve supplies the two muscles with C5 and C6 segments. Then the other point is you can see the intermuscular septa here, lateral intermuscular septum, and the medial intermuscular septum somewhere here. It's not labeled in this diagram. Medial intermuscular septum somewhere there. And in the anterior compartment, you can also see there is median nerve and the brachial artery and its vena committantes. And in the posterior compartment, you see the ulnar nerve and superior ulnar collateral artery with its vena committantes here. I'll come back to it in the next slide. So the ulnar nerve and the superior ulnar collateral artery, they initially lie in the anterior compartment, and then later they pierce the intermuscular septum, medial intermuscular septum, and enter the posterior compartment. In the posterior compartment, you can see other than the three heads of the triceps muscle, you have the profunda brachii artery, or the deep artery of the arm, and the radial nerve, deep artery of the arm and the radial nerve. Now the radial nerve, it is at this point the radial nerve can supply the brachialis muscle. So it's very close to the radial nerve, while the radial nerve is in the radial groove, just before it comes out. It can actually supply the that small part of the brachialis muscle. Remember that point. Okay, so this is that point that I mentioned here. Then this is the other point that I mentioned, this ulnar nerve and the superior ulnar collateral artery, ulnar nerve and the superior ulnar collateral artery with its vena committantes, even though it's not shown here, leaving the anterior compartment and entering the posterior compartment by piercing the medial intermuscular septum. Okay. Then same thing with the radial nerve. There are a lot of points about the radial nerve. Again, as I mentioned in the previous lecture, all segments of the brachial plexus C5 to T1 are carried in the radial nerve. Okay, so that is the first point that you need to remember. C5, 6, 7, 8, T1 all carried in the radial nerve. Then in the axilla, it gives a posterior cutaneous nerve of the arm with only a cutaneous branch in the upper part. And in the axilla, the important point is, in the axilla, it gives the branch to the long head of triceps. So for that reason, if you damage the radial nerve, and even the medial head is supplied from a branch, high branch. So this is before the radial nerve enters the radial groove in the arm. So if you damage the radial nerve in the radial groove, because of this supply, triceps will not be paralyzed, because the long head is supplied there, and part of the medial head get one of its supplies at that point. Then later, medial head is supplied again while the nerve is in the radial groove. So this is an important point. So you don't get wrist drop, not wrist drop. You don't get loss of total, extension of the elbow joint if you damage the radial nerve in the radial groove. Of course, you get wrist drop if you damage the radial nerve in the radial groove, but you don't get loss of extension of the elbow joint because of the active triceps muscle. Then the other point here is that I want to mention is that once it enters the elbow joint, it enters, I think there is some text here, yeah. It enters the cubital fossa in front of the lateral epicondyle, and immediately after it enters the cubital fossa, it divides into a deep branch and a superficial branch. Deep branch enters the supinator muscle. It passes between the two heads of the supinator muscle. It has a humeral head and an ulnar head. So it passes between the two heads of the supinator muscle. It enters as the deep branch, but it leaves as the posterior cutaneous nerve of the posterior interosseous nerve of the arm. Enters as deep branch of the radial nerve and leaves as the posterior interosseous nerve of the posterior interosseous nerve branch of the radial nerve. And the superficial branch supplies the dorsum of the hand and fingers. The superficial branch. Okay. So this is these are the branches of the radial nerve. So this is what happens. The deep branch of the radial nerve enters the supinator muscle, and it leaves as the posterior cutaneous, posterior interosseous nerve. Okay, don't get mixed up. Posterior interosseous nerve. And if you look at this diagram, if you look at the diagram again, so brachialis, I mentioned this point. Okay. So this is the point. Now, at the elbow, it divides into the superficial branch and deep branch. Okay. Deep branch supplies extensor carpi radialis brevis and supinator muscles in the forearm. Then the rest of the muscles, the extensor digitorum, extensor digiti minimi, and so on, those muscles are supplied by the posterior interosseous nerve. So technically, supinator, even though the posterior interosseous nerve emerges through supinator, actually the supinator is supplied by the deep branch of the radial nerve. Then only it becomes the posterior interosseous nerve. Then the other point is that the brachialis muscle, other muscles of the extensor compartment of the forearm, brachialis muscle and the extensor carpi radialis longus muscle, as you can see, they are supplied in the arm. You always, go by this guide. It's axilla, upper arm or arm, that's what we call arm, and the forearm. So the brachioradialis and extensor carpi radialis longus are supplied in the arm. So it's from the radial nerve. Therefore, they are not affected if you damage the posterior interosseous nerve or the deep branch of the radial nerve. So you will not get wrist drop. For you to get wrist drop, you have damaged either the deep branch of the radial nerve or the posterior interosseous nerve. Okay, because it's not the brachioradialis, but the extensor carpi radialis longus can extend the wrist joint. If you damage the posterior interosseous nerve, again, even the extensor carpi radialis brevis is there to extend the wrist joint, because that is given off before the posterior interosseous nerve is formed. I think you can understand this point that I am going to raise here. Then this is the superficial branch of the radial nerve, which actually passes over the anatomical snuff box, over the roof of the anatomical snuff box. It's a cutaneous nerve and supplies the lateral aspect of the dorsum of the hand, you know this area, there is a lot of overlap between cutaneous nerves, and you might get some small area in the end that is actually supplied by this branch. Okay, so area of sensory loss ultimately would be something like that, even though the supply is wider, because there is a lot of overlap by the median and ulnar nerves in that area. Okay, then few things about the median nerve. Now that we discussed the other nerves, again the median nerve, all segments of the brachial plexus are carried in the median nerve as well as in the radial nerve. And the important point is that in the axilla, so this is axilla, in the axilla there are no branches. Okay, there are no branches given from the median nerve in the axilla. Then this is arm or upper arm, whatever you call it. Then point that I wanted to mention, it enters the forearm just lateral, just medial to the brachial artery, and in the forearm, and it enters the forearm between the two heads of pronator teres muscle. I'll come back to it. Between the two heads of pronator teres muscle, and gives a deep branch which is called the anterior interosseous nerve. Now, the posterior interosseous nerve is a branch from the radial nerve. Anterior interosseous nerve is a branch from the median nerve, and the anterior interosseous nerve, you can see the muscles supplied by the deep muscles, the muscles of the deep compartment of the forearm, the flexor pollicis longus, flexor digitorum profundus, and the lateral half, and the pronator quadratus. The three muscles are supplied by the anterior interosseous nerve. Then the main trunk of the median nerve will supply the superficial layer of muscles in the anterior compartment, like flexor carpi, radialis, palmaris longus, flexor digitorum superficialis, and so on, with the pronator teres at the beginning. So then these are the points that I wanted to raise, and then the palmar cutaneous branch, which is an important branch because it's given off proximal to the flexor retinaculum of the forearm. We'll come back to it, the discussion, and therefore it is spared in carpal tunnel syndrome, so that you get no sensory loss over the thenar eminence because of the palmar cutaneous branch. Then the other thing is the median nerve will supply the lateral 3.5 fingers. Okay, by cutaneous supply this one. Okay, and the lateral, the two lumbricals and the thenar muscles. Of course, you know this. Then small clinical point, this Struther's syndrome or supracondylar process syndrome. Now the basis of the condition is that some people can have a supracondylar process, an additional one. Supracondylar process on the anteromedial aspect of the humerus, about 5 centimeters, proximal to the medial epicondyle. Now, when the process is there, usually there is a ligament attached between this process and the medial epicondyle. Okay, so that ligament is called Struther's ligament. And the median nerve and the brachial artery passes through the arch formed by the process and the ligament, and they are vulnerable for compression in that area. And when the median nerve is compressed, you get pain, paresthesia, and numbness over the distribution of the median nerve in the forearm and the hand. And other than that, you can get positive Tinel's sign. Tinel's sign is, when you tap a nerve, if you suspect median nerve compression here, if you tap the nerve, you get pain and tingling sensations. Tingling sensations are pins and needle sensations. Okay, pins and needle sensations over the distribution of the nerve. So that is about the Struther syndrome. Then there is another condition called Pronator teres syndrome. It is just distal to where you get the Struther's syndrome. Pronator teres syndrome takes place somewhere here when the nerve passes between the two heads of the pronator teres muscle. Okay, two heads of pronator teres muscle, you get the Pronator teres syndrome. And And again, you get a similar issue. You get pain and numbness and sometimes weakness of forearm muscles supplied by the median nerve. Specifically, if I mention something, that they have difficulty in pinching firmly. If they are asked to pinch firmly, where you use the index finger and the thumb, due to the weakness of flexor pollicis longus to the thumb and the flexor digitorum profundus to the index finger, which are necessary for pinching, due to the weakness of these muscles, you get in either inability or weak pinch movement. Then dropping things. They frequently drop things because their flexors are weak. So for you to hold something in your hand, you have to have the flexors functioning properly. Then the other thing is the symptoms are exacerbated if you do sustained pronation. If the patient does sustained pronation, then the symptoms are exacerbated because the compression becomes more when the muscle contracts here. And this compression, even though we call it pronator teres syndrome, actually it can happen just distal to the pronator teres at the fibrous arch of the flexor digitorum superficialis, because the flexor digitorum superficialis has an origin like this from both bones here, radius and ulnar. So in that arch, it can get compressed again. Okay. Then about the ulnar nerve. Now usually ulnar nerve carries two segments, C8 and T1, but it is possible in sometimes you get C7 segment coming into the ulnar nerve as a branch joining the ulnar nerve from the lateral cord. So that is possible. So you can remember the ulnar nerve as the last three segments of brachial plexus, C7 to T1. Okay, but C7 is not there always. Okay, it can be there. Again, it has no branches in the axilla. It has no branches in the axilla. The important point is that it supplies the flexor digitorum profundus medial half. Lateral half is supplied by the median nerve. So it's clinically very important, because when you get nerve injuries, you get a picture based on this supply. Then other than that, the ulnar nerve supplies all interossei of the hand, and it supplies the medial two lumbricals, third and fourth lumbricals, and it usually ends by supplying the adductor pollicis muscle. And the cutaneous supply, it supplies the medial 1.5 fingers and that medial end of the palm and the dorsum both. So then this is about the ulnar nerve that I wanted to mention. Ulnar nerve entrapment syndromes are also there. Typically there are two sites where ulnar nerve can get compressed. It can get compressed at the elbow joint. When it gets compressed at the elbow joint, you call it cubital tunnel syndrome. When it gets compressed at the wrist joint, or rather in the proximal part of the palm, you call it Guyon's canal syndrome. So it's either cubital tunnel syndrome or Guyon's canal syndrome. And the cubital tunnel syndrome is more common actually. The cubital tunnel is a fibro-osseous space here formed by a ligament passing between the medial epicondyle of the humerus and the olecranon of the ulna here. So these 2 points are the 2 points where the two heads of flexor carpi ulnaris muscle is attached. Now when the ulnar nerve enters the forearm, we say that it passes through the two heads of flexor carpi ulnaris muscle. So one head is here, another head is there. Between the two heads, you get this ligament attached. Okay, and the nerve passes through that. It can get compressed at that point. Then you get cubital tunnel syndrome. It's the same thing. You get pain, paresthesia, numbness over the distribution of the ulnar nerve. So this side, you get these symptoms, and then you get the weakness of muscles supplied by the ulnar nerve. So it's the flexor carpi ulnaris and the medial half of flexor digitorum profundus and the hypothenar muscles here, with all the interossei and medial two lumbricals. Okay. Then the Guyon's canal syndrome Now there fibroosseous canal is formed over the flexor retinaculum, and that is actually due to a ligament which is called the palmar carpal ligament, which lies proximal and superficial. Okay, remember, proximal and superficial to the flexor retinaculum. If you have the flexor retinaculum like that, this one is superficial to the flexor retinaculum. Okay. Then the ulnar nerve and the ulnar artery pass through it, and the nerve and most probably the artery also divides into its deep and superficial branches at the distal part of the Guyon's canal. So there it can get compressed, and sometimes using crutches can compress because you use the palm to hold the lower end, and the bicycle handlebars can cause it, and fracture of the hook of the hamate also can cause it. And even if there is a space occupying lesion here for some reason, again it can cause compression of the ulnar nerve in the Guyon's canal. So that is the second variant of the ulnar entrapment. Then someone's phone is working. You have to mute yourself. Okay. Then okay, so now this is just to show it's very difficult to find a diagram in the internet with the two ligaments. Now this is your flexor retinaculum. Sorry, this is your flexor retinaculum, which is also called transverse carpal ligament, the same as the flexor retinaculum. And this is your palmar carpal ligament. Palmar carpal ligament, which is cut and raised to show you the ulnar nerve and ulnar artery lying between the flexor retinaculum and the transverse carpal ligament here. Okay. Then about the anastomosis around the elbow joint, it might not be as important as the scapular anastomosis, but it's better at postgraduate level. It's better to have an idea about the elbow anastomosis. Now this is how you remember it. There are four collateral arteries. 1, 2, 3, 4, and there are four recurrent arteries. 1, 2, 3, 4 basically. So this 4 will form the anastomosis. Now the collateral ones are given proximally, and they follow the direction of the main artery. That's why you call them collaterals. Okay. And the recurrent ones, they start distally and they go in the opposite direction. Okay, from distal to proximal. That's why you call them recurrent. So the first two collateral arteries are the superior and inferior ulnar collateral artery. Superior one is given above proximally at a superior level, and the inferior one is given at an inferior level from the brachial artery. That's why they are called superior and inferior, based on their origin from the brachial artery. So it's the superior ulnar collateral artery that actually goes with the ulnar nerve, pierces the medial intermuscular septum and enters the posterior compartment of the arm. And then you get the radial, the deep branch of the deep artery of the arm continues as the radial collateral artery. Okay, and it gives a branch in the radial groove which is called the middle collateral artery. So you are finished with the four arteries there: superior ulnar collateral, inferior ulnar collateral, radial and middle collateral arteries. Then the recurrent arteries, now to anastomose with the superior and inferior ulnar collateral arteries, you get two recurrent arteries. They are named based on their relationship to the medial epicondyle. One that is posterior to it is called posterior ulnar recurrent. One that is anterior is called anterior ulnar recurrent. Now that the superior collateral artery comes behind the medial epicondyle, that anastomoses with the posterior ulnar recurrent artery. And the anterior ulnar recurrent artery anastomoses with the inferior ulnar collateral artery, because that lies in front of the medial epicondyle of the humerus. Then the radial recurrent anastomoses with the radial collateral here, okay, given off from the radial artery, of course. Then the interosseous recurrent given now from the interosseous, common interosseous artery here, interosseous recurrent, anastomosis with the middle collateral artery. Okay, so you might not be able to remember these things exactly like this, but have some idea, at least have an idea that there are four, okay, given from the brachial artery and the deep artery of the arm, and then from the ulnar artery and the radial and common interosseous arteries. Okay, that is it. Then about the cubital fossa. So this is your cubital fossa. It is defined as an area bounded proximally by a line passing between the two epicondyles of the humerus, medial and lateral epicondyles. That is the base. Then the triangular area, the medial border is formed by the lateral border of the pronator teres muscle, and the lateral border is formed by the medial border of the brachio radialis muscle. And the flow actually is formed by the biceps, the brachialis muscle and the supinator muscle in the distal part. Brachialis is in the proximal part, and the roof is formed by the deep fascia here. So you know this part, I need not spend too much time on this. And when it comes to contents of cubital fossa, the main contents that is mentioned in most of the places are the tendon of biceps, the median nerve, brachial artery and its vena committantus, the biceps tendon, and the lateral cutaneous nerve of the forearm, the continuation of the musculocutaneous nerve. These are the main branches, the main contents of the cubital fossa that are usually mentioned. But actually, if you read the descriptions in anatomy textbooks, actually you will be able to add radial and ulnar arteries, because it says that the brachial artery divides into radial and ulnar arteries at the distal part of the cubital fossa. Therefore, you can actually include them. Then the radial nerve actually divides into, even though it lies slightly under cover of brachioradialis here, the moment you lift the brachioradialis, actually you can see the nerve. So from a clinical point of view, it's okay to add it, even though it's exactly not inside the cubital fossa, it's slightly outside the lateral margin. So you can add actually the radial nerve and its superficial and deep branches. Then now you cannot say the posterior interosseous nerve, okay, even though it says posterior interosseous nerve here in this one. Actually you technically you call it once it emerges from the after passing through the supinator muscle. Therefore this is actually a deep branch of the radial nerve, so that can be added if you want as a content, not the posterior interosseous nerve. Then so this I mentioned. Then actually if someone says anterior ulnar recurrent artery and the radial recurrent artery, which are this one and this one, yeah, ulnar recurrent is not clearly shown here, but anyway, these also here anterior ulnar recurrent, these also can be added. So this is for MCQs, if somebody wants to check this one. Okay, so you might have issues with this, but I checked several sources. This question came up during maybe in the last year lecture. Okay. Then few things about the elbow joint. Elbow joint is a complex joint. It is on one side you get the humerus, on the other side you get radius and ulna both. So you can divide the joint into two parts actually. The humero-ulnar part, the part between the humerus and the ulna, actually it is the trochlea of the humerus and the trochlear notch of the ulna. So that is that part, trochlea of the humerus and the trochlear notch of ulna. It is actually hinge type joint. Okay, that part is a hinge type joint. Then the second part of the joint is the humero-radial part, that is between the capitulum of the humerus and the head of the radius. That is actually a pivot type joint. Okay, it is actually a pivot type joint. So this whole thing will make the elbow joint, and it's a here hinge type. Even though the pivot type is also inside, you mainly call it as a hinge type joint. Okay, So remember the difference. Okay, you can have, if somebody specifically asks, this is actually hinge as well as pivot. Okay, so it's a uniaxial hinge type synovial joint. So in an essay, if you write about the elbow joint, remember this statement. Okay, so it's easy to write it that it's a uniaxial. Don't just write the synovial joint. It's a uniaxial hinge. At separate places, you write them at the same place. Uniaxial hinge type synovial joint. Okay, and it's a relatively stable joint with bony factors and ligament factors helping in the stabilization of the joint. And most importantly, the joint continues into the superior radioulnar joint, superior or proximal radioulnar joint. Okay, the joint cavity continues into that. Okay, the capsule is attached to the radio and ulnar collateral ligament. That's a different issue. Okay. Then about the ligaments, the radial collateral ligament is a triangular ligament. As you can see in the diagram, it's a triangular ligament here. So its apex is at the lateral epicondyle. Apex is at the lateral epicondyle, and base is attached to the annular ligament here. So you get the annular ligament here. Okay. So that is radial collateral ligament or the lateral collateral ligament. Then the medial collateral or ulnar collateral ligament has three bands. The anterior band is attached between the medial epicondyle and the coronoid process of ulna here. The posterior band is again between the medial epicondyle and the olecranon, and there is a transverse band between the attachment of the two anterior and posterior bands, that is between the coronoid process of ulna and the olecranon. Okay, so these are the three bands of the ulnar collateral ligament. The synovial membrane, as I said before, synovial membrane of the elbow joint, it is shared by the proximal radioulnar joint as well. Same synovial membrane continues into the proximal radioulnar joint. Few things about the forearm. Again, like the arm, forearm is also divided into two compartments, two main compartments: the anterior compartment, this one, and the posterior compartment, the flexor compartment and the extensor compartment. And this sometimes, this side is taken as a lateral compartment, but mostly it is put under the extensor compartment. So this whole thing will be taken as the extensor compartment usually. Okay, not that you cannot call that a lateral compartment. I'll show you in one of the slides. Okay, then if you take the both anterior and posterior compartments, you can see the compartments has two sub-compartments, a superficial one and a deep one. Here also you have a superficial one and a deep one. So that is the point that you need to remember here. And the neurovascular structures, they lie between the superficial and deep compartments, sub-compartments. Okay, here you get the posterior interosseous nerve and artery. Here you get the median nerve, ulnar artery and ulnar nerve. Okay, so that is the point that I wanted to raise. Then the anterior compartment, if you take the superficial part, you get these muscles. You get this, this 5-finger business you have learned in your undergraduate thing. So you, from the thumb, you start the pronator teres. If you put on the cubital fossa, the 5 fingers spread out, this is pronator teres. Then flexor carpi radialis, palmaris longus, flexor digitorum superficialis and flexor carpi ulnaris. So these are the 5 muscles in the superficial compartment. But you have to remember that the flexor digitorum superficialis, it lies at a deep level compared to the other 4 muscles, lies at a deeper level. For that reason, people sometimes call this as the first layer and this as the second layer, even though they are both in the superficial compartment. Okay, then similarly, when it comes to the deep layer, deep part, you get flexor digitorum longus, so flexor pollicis longus, flexor digitorum profundus and pronator quadratus. Again, pronator quadratus lies deep to the other two, the tendons of the other 2 muscles. So they are at 2 levels. So, you know, because of this, people call this the 3rd layer, and this is the 4th layer. If you continue with the first 2 layers, 1, 2, 3, and 4. Okay. So I prefer to call it superficial and deep. Okay, rather than calling it 1, 2, 3, 4. But here you get, this is from Grant's Atlas. They have used this 4-layer business. Okay, 4-layer business. So in the superficial compartment of the anterior compartment, you get 4 muscles, superficial, the first layer, and the flexor digitorum superficialis in the second level. Okay. So brachioradialis will go to the posterior compartment. Then the deep layer of the anterior compartment, you get the flexor pollicis longus and flexor digitorum profundus, and deep to the tendons here, deep to them, you get the pronator quadratus. So you call it 4th layer in this classification. Okay, it's not very important, I think. Whether it's 4th or 3rd, you know, you should know the muscles. Then few points about pronator teres. We already discussed about pronator teres syndrome. Now we know that there are 2 heads of pronator teres between which you get the median nerve entering the forearm. There is a humeral head and an ulnar head. Now the median nerve enters the forearm between the 2 heads, and the ulnar head. So this is the ulnar head. Ulnar head lies between the median nerve and the ulnar artery. Median nerve and the ulnar artery. Okay. Ulnar artery and radial artery are given here. Immediately after the ulnar artery is given off, the medial head, the ulnar head of pronator teres lies between the median nerve and the ulnar artery. Okay, so remember that point. And the lateral border, okay, that you know, it forms the lateral border of the cubital fossa. It's the medial border, sorry, it's the medial border of the lateral border is the medial limit of the cubital fossa. Yeah, that's true. Then about the pronator teres, it's important. It's stronger than pronator quadratus, and it acts during rapid or forcible pronation, whereas the pronator quadratus is active throughout in all sorts of pronations. Okay. Then compartments, the posterior compartment. Posterior compartment is more complicated than the anterior compartment. Now the posterior compartment, if you go by the muscles, the brachioradialis muscle and the extensor carpi radialis longus muscle, we have already mentioned that they are actually attached to the supracondylar ridge, the lateral supracondylar ridge, and they are supplied by the radial nerve, and therefore they are not paralyzed if you damage the deep branch of the radial nerve or the posterior interosseous nerve. That is one thing. Other thing is the brachioradialis muscle, which is this one. Brachioradialis muscle is attached to the distal end of the radius here. Therefore, it has no action on the wrist joint. It cannot move the wrist joint. Its action is actually on the elbow joint here. Okay, it's a flexor of the elbow joint, as well as a pronator and a supinator. It's a pronator and a supinator. If you fully supinate the forearm, you can half pronate it by the brachioradialis contraction while flexing the elbow joint. At the same time, if the forearm is fully pronated, you can half supinate it. Okay, it's only half by the brachioradialis. Okay. Then the extensor carpi radialis brevis, extensor carpi ulnaris, extensor digitorum, and extensor digiti minimi and anconius. They are the other superficial muscles. Then the deep layer, you get the supinator, then the abductor pollicis longus, brevis, extensor pollicis longus. They are going into the thumb. They are all going into the thumb. That's why you get the pollicis here. Then the extensor indicis. Okay, we see the muscles here. So this is the first the superficial level muscles. This one and this one, and this is the deep layer. This one is the deep layer. So these carpi, extensor carpi radialis longus, radialis brevis, extensor carpi ulnaris, they are all wrist extensors. Like flexor carpi radialis and flexor carpi ulnaris, They are wrist flexors in the anterior compartment. Extensor carpi radialis longus, brevis, and extensor carpi ulnaris are wrist extensors in the posterior compartment. Then you get the flexor the extensor digitorum and extensor digiti minimi in the superficial, whether it's superficial or deep, it doesn't matter, you can remember them. Then the deep one, you get supinator. Anconius is a muscle there. It's actually an extensor of the elbow joint, supplied by the radial nerve. Okay, it's supplied by the radial nerve. Then the supinator, it's an important muscle that with the biceps it supinates the forearm. We'll come back to it in the future slide. Then the three pollicis muscles, abductor pollicis longus, extensor pollicis brevis, and extensor pollicis longus, they contribute to form the boundaries of the anatomical snuff box here. Okay, abductor pollicis longus and extensor pollicis brevis will form the lateral boundary in the anatomical position, and the extensor pollicis longus will form the medial boundary in the anatomical position. Then you get the extensor indicis last. Okay, and all these muscles, they are supplied by the posterior interosseous nerve. Posterior interosseous nerve. Even some of these are supplied by the posterior interosseous nerve, and this one is supplied by the deep branch of the radial nerve, and this is supplied by the radial nerve itself. And the brachioradialis, as I said before, and extensor carpi radialis longus, they are also supplied by the radial nerve before the deep and superficial branches are given. Okay. Okay, just to show you how the posterior interosseous nerve emerge through the supinator muscle, through heads of supinator muscle, and supply the muscles here. Then this concept of proximolateral compartment, some anatomy authors use this, and when they use it, proximolateral compartment, they actually include brachioradialis and extensor carpi radialis longus and brevis muscles there. Okay, so the brachioradialis and extensor carpi radialis longus and brevis muscles are included in the proximolateral compartment. So in that case, if you do that, then you have an anterior compartment, a posterior compartment, and a lateral or proximal lateral compartment, including these three muscles here. But I prefer this anterior and posterior business rather than adding this to complicate the matters. Then just to remind you about this tennis elbow and golfer's elbow. Tennis elbow is the overuse of extensor muscles, and the issue arises at the lateral epicondyle, the inflammation at the lateral epicondyle, and the golfer's elbow is due to overuse of flexor muscles, and the pain and tenderness is at the medial epicondyle level, where you get the common common flexor origin. This is common extensor origin. So even our people, they, even though they don't play tennis and tennis and golf all the time, with sweeping and other household work, housewives tend to get both these conditions. Okay, tennis elbow or golfer's elbow, because repeated use of extensor and flexor muscles, they can get it. Okay, a few things about the proximal radio-ulnar joint. It is between the head of the radius and the radial notch of the ulna. Okay, radial notch of the ulna, head of the radius and radial notch of the ulna. And there is a ligament called annular ligament holding the head of the radius at the joint. So it's attached on either side of to the edge of the radial notch on the ulna. So this is your ulna. Okay, radial notch is here for the head of the radius. So in the annular ligament, the inner aspect of the annular ligament is actually lined by cartilage, hyaline or fibrocartilage, and the joint is connected with the elbow joint. As I said before, it's a uniaxial synovial pivot type joint. Okay, pivot type joint. So this I mentioned, and this also I mentioned. So the radial head rotates within this during pronation and supination. We'll come back to pronation and supination again. Then the distal radioulnar joint, on the radius in this case, there is an ulnar notch distally. So it's the ulnar notch on the distal end of the radius. This is the head of the ulnar. So the head of the ulnar articulates with the ulnar notch on the distal end of the radius. So that is the first point. Then it is again a uniaxial, just like the proximal one, uniaxial synovial pivot type joint. Now the distal, unlike the proximal radioulnar joint, which was connected to the elbow joint, distal radioulnar joint, it is not connected to the wrist joint. Okay, it's closed up. It's closed from the wrist joint because of a fibrocartilage articular disc, which is just distal to the head of the radius, attached between the distal end of the ulnar notch on the radius and the base of the ulnar styloid here. I'll show you in a different. Okay, so this is you can understand. You can identify the ulnar styloid here, and you get the radial styloid here. Okay, so this is the distal radioulnar joint here. So if you draw this triangular fibrocartilage, this is how it is. It's attached to this distal margin of the radial ulnar notch on the radius and the base of the ulnar styloid here. Okay, so it prevents the connection between the distal radioulnar joint and the wrist joint. So the wrist joint is mainly formed by the distal end of the radius and the scaphoid and the lunate on the proximal row of carpal bones. During now you know the pronation and supination. In your anatomical position, your forearm, the palm is facing anteriorly, you know that. So that is your supinated position. That is the supinated position when the palm is facing anteriorly. Then when you pronate, in full pronation, palm faces posteriorly. If you are in the anatomical position, if you turn it, now the palm is facing to the posterior side in pronation. So this is half pronation, the neutral position. So as we said before, the brachioradialis is actually helping either to bring it this way or bring it that way, not beyond that. So that is the best position for the brachioradialis to flex the elbow joint. So this is the strongest position of the brachioradialis to flex the elbow joint, the mid position or neutral position of the forearm. And the other point is, as you can see here, when in the supinated position, the thumb lies on the lateral side, and in full pronation it lies on the medial side with the palm facing backwards. It is the radius that rotates here during pronation and supination, with the distal end of the radius lying either parallel to the ulna or lying across the ulna. Since the wrist joint is only between the hand and the radius, it moves with the radius. So if you are asked to describe or whatever about pronation and supination, which was there in one of your past questions, all these points has to be there. Okay, and importantly the axis. Okay, the axis of pronation and supination passes from the center of the radial head here, center of the radial head, to the base of the ulnar styloid. Okay, so this is the axis of pronation and supination. It's an oblique axis. Then the other important point is, even though the ulna does not rotate, but it moves to give space for radius. Okay, so you can do it, you can practice it on your forearm and see. If you put your finger on the ulna and do pronation and supination, you will see that the ulna moves. Okay, but it does not rotate. Okay. Then pronators and supinators. Now there are several muscles that can contribute to pronation and supination, like brachioradialis and even the long flexors and extensors. Okay, they can help in pronation and supination, but the main supinators are the biceps brachii and the supinator muscle. They are the main supinators, and the main pronators are the the pronator teres and the pronator quadratus. So that is the first thing to remember. Then the attachment of the, when it comes to supination, the attachment of the supinator and the biceps is such that when they contract together, there is rotation of the radius like that. Biceps is attached to, now this is the radial tuberosity. The biceps is attached posteriorly on the radial tuberosity, not here. Okay, because of that, and when it comes to supinator, it's attached to the lateral side of the radius. So because of these two attachments, this rotation can take place. Okay, so that is one thing. Then when it comes to nerve supply, the pronators are supplied by C7 and C8. The supinators, the biceps and supinator, are supplied by C6 segment. So when you get upper root brachial plexus injuries, brachial plexus upper root injuries where C5 and C6 are damaged, supination is affected, not pronation. So the arm is kept in the pronated position, which is the waiter stip position. There are other deformities other than that at the shoulder level as well. But remember, when it comes to pronation and supination, in upper root injuries, supination is affected but not the pronation. So arm is kept, the forearm is kept pronated rather than supinated. Okay. So we discussed these nerves in a previous slide in detail. Just to summarize it, the radial nerve divides into a deep branch and a superficial branch. The deep branch enters the posterior compartment, passing through the two heads of the supinator muscle. The median nerve enters the forearm through the two heads of pronator teres. Ulnar nerve enters the forearm through the two heads of flexor carpi ulnaris. Okay, so remember that point as well. Okay, just to show you the same thing, posterior interossei nerve and all. Then at the anterior aspect of the wrist, I don't know whether we should take a small break. Shall we take just a 5-minute break? Okay, just a 5-minute break. Okay, then we will start again. Okay, we will continue from there. Now, anterior aspect of the wrist, if you look at the anterior aspect of the wrist, there are a few things that I want to mention, not everything. Now, the median nerve in the anterior aspect of the wrist lies between the palmaris longus tendon and the flexor carpi radialis tendon. Okay, palmaris longus and flexor carpi radialis tendon, partly under cover of the palmaris longus tendon. So they are very close here, palmaris longus and median nerve. So this is important when it comes to nerve conduction studies and all, to keep the probe, whatever. Okay, and usually another thing that you can remember, you get two main nerves here, the median nerve and the ulnar nerve. Then you get two arteries, the radial artery and the ulnar artery. Now the arteries lie lateral to the nerves. Okay, radial artery lies lateral to the median nerve and the ulnar artery lies lateral to the ulnar nerve. Okay, so it's an easy way to remember it. Then, I will not talk about all other tendons here. It's a straightforward thing. Then about flexor and extensor reticula. Flexor and extensor reticula. Flexor reticulum is attached laterally to the tubercle of the scaphoid and the ridge of the trapezium. And medially it is attached to the hook of the hamate and the pisiform. Hook of the hamate and the pisiform. Then the extensor retinaculum, on the other hand, laterally is attached to the distal end of the radius here, and proximally it is attached to the pisiform and the triquetral. Okay, pisiform and the triquetral. Here you can have different versions in some books. Some people might say that it's attached to the hook of the hamate. There is a version like that also, but better you go by this one. Okay, pisiform and triquetral. Then I will not go into the carpal tunnel. It's a very common thing that everybody knows, but just to mention the main points, the issue is with the carpal tunnel syndrome is the median nerve passing through the carpal tunnel. median nerve passing through the carpal tunnel. So when the pressure rises, median nerve compression can take place. The clinical picture, the anatomical point here is the clinical picture is not very straightforward because one thing is that the ulnar nerve is spared because it passes superficial to the flexor retinaculum, and the other point is the palmar cutaneous branch of the median nerve is spared because it passes superficial to the flexor retinaculum, and the palmar cutaneous branch happens to supply the skin over the thenar eminence. On the other hand, muscles of the thenar eminence are supplied by the recurrent branch of the median nerve, which is also called thenar motor branch of the median nerve, which you can see here, which is given off distal to the flexor retinaculum. The flexor retinaculum is somewhere here, distal to the flexor retinaculum. So the clinical picture is that you get weakness of muscles, atrophy of muscles in the thenar eminence, but the skin over the thenar eminence is intact. There is no loss of sensation because of the palmar cutaneous branch. On the other hand, movement of the fingers is not affected because the flexors are supplied proximal to the flexor retinaculum, but the sensations are affected in the lateral 3.5 fingers because the digital nerves are given off distal to the flexor retinaculum. So that's the only thing to remember in carpal tunnel syndrome. So this is a nice specimen we had actually in the anatomy block to show you the recurrent branch of the median nerve. The arrow indicates the recurrent branch of the median nerve. This is your flexor retinaculum cut. Okay, just distal to the flexor retinaculum. So it's the variations of this, the origin of this nerve is common. Variations are common, and there is a risk of damage during carpal tunnel release. Okay, so if you put an incision like this, a radial side incision, there's a risk of damage because of the variations. Okay, so I have read articles, you can read, there are many research articles on this. You should put an incision, ulnar side incision. I don't know which direction they put it. Anyway, they suggest an ulnar side direction rather than radial side direction to avoid damage to the recurrent motor branch. Then about the superficial palmar arch of arteries. Superficial palmar arch is formed by the ulnar artery, this one, with the superficial branch of the radial artery. So what happens is ulnar artery gives a deep branch and continues to form the superficial palmar arch. Radial artery, on the other hand, gives a superficial branch and continues through the anatomical snuff box here. Later it will enter the deep aspect of the palm. That's a different issue. Then commonly this superficial palmar arch is commonly an incomplete arch. Okay, commonly an incomplete arch without the superficial branch of the radial artery. So the arch is only formed by the half arch, only formed by the ulnar artery in that case. No superficial branch from the radial artery. Okay, so this is an example of a superficial palmar arch, an incomplete part. So it's only the ulnar artery that forms the superficial palmar arch in this case. Deep palmar arch, on the other hand, is commonly a complete arch. It's commonly a complete arch formed by the deep branch of the radial ulnar artery and the continuation of the radial artery. Okay, radial artery is formed in dotted lines here because it passes through the anatomical snuff box behind the thumb and comes between the thumb and the index finger through the two heads of the dorsal interosseous. Okay, and enters the palm again and anastomosis with the deep branch of the ulnar artery. And if you put the deep branch of the median, the ulnar nerve, deep branch of the ulnar nerve in relation to the deep palmar arch, you will have to put it proximal to the deep palmar arch. Okay, that is the deep branch of the ulnar nerve. Okay, proximal to the deep palmar arch. So this is again a specimen to show you the artery and the nerve. So this is the nerve, deep branch of the ulnar nerve, and this is the deep branch of the ulnar artery. Allen test. Uh, Allen test is a test where you examine the radial and the patency of the radial and ulnar arteries. So you do one artery at a time, the patency of one artery at a time. So what you do is you block both arteries and raise the arm so that you get the palm free of blood. Then you release one artery, and if that artery is patent, you should get reperfusion within few seconds. But if that artery is not insufficient, you will not get reperfusion during the given time period. So you label it as insufficient. So this is important when you do AV fistulas and all for these patients with renal failure and all. So you cannot use an artery if the other one is insufficient. Okay, if you want to use an artery, the other artery should be sufficient. So you do the Allen test. Remember the basis. This can be asked in your Viva component. It has been asked at least. So these are the steps. So you get the PDF lecture, you go through the steps. I will not read the steps. Okay, they are available in any standard clinical anatomy book. I will not go through the steps. They are put step by step. There are some variations of the Allen test. I think you better go by this test, or you go by whatever clinician would tell you. Okay, because they are the ones who practically do it. But I think this version is better than other versions. Okay, so you go through it. Then palmar spaces. Palmar aponeurosis is a triangular shaped thing with the base distally and the apex proximally here. Now there are two fibrous septa. One is attached to the lateral border of the palmar aponeurosis. The other one is attached to the medial border of the palmar aponeurosis. So the lateral septum is attached to the lateral border, and the other end, the deep end, is attached to the third metacarpal, the metacarpal of the middle finger here, and here is the metacarpal of the little finger, fifth one. So you can see the lateral and especially the lateral border of the palmar aponeurosis, and this one is not at the same same level laterally. So this septum should be oblique to get attached to the third metacarpal bone. So the two fibrous septa, medial and lateral fibrous septa, divide the palm into three spaces. Lateral to the lateral septum, you get the thenar space. Medial to the medial septum, you get the hypothenar space, and between the two septa, you get the mid-palmar space. Okay, mid-palmar space. So lateral to the lateral septum, which is this one, you get the thenar space. Then medial to the medial septum, you get the hypothenar space. Then in between the two septa, you get the mid-palmar space. Now, even though it is attached to the palmar aponeurosis, as we said before, palmar aponeurosis here. Okay, space is not the whole area, because you get all these tendons and things like that. You get muscles. Now, when it comes to thenar space, you can see the whole area is not space. You get your adductor pollicis and other long tendons. In between only you get the space, potential space. Okay. So thenar space therefore lies in these blue areas are the spaces. So hypothenar space is not clinically important. So it will not be considered even in your answers to a question. If you ask to write about spaces, palmar spaces, you can just mention the hypothenar space, but you don't have anything to write about it. Okay, you can just mention the muscles that are there and then finish it off. But then the thenar space and mid-palmar space are important, and as you can see here, thenar space lies between the long flexor tendons to the index finger and thumb. So long flexor tendons to the index finger and thumb. Okay, so they are these long flexor tendons, and that is superficially. Then the deeply you get the adductor pollicis muscle. In between only you get the thenar space, and the first lumbrical going into the index finger lies in the first the thenar space, first lumbrical. Similarly, the mid-palmar space lies between the here long flexor tendons to middle finger, ring finger and little finger. Middle finger, ring finger and little finger. So those are these ones. Okay. Those are these, and they're synovial sheaths. That is superficially. Then deeply, you get the interossei and the three lateral, the three medial, third, fourth, and fifth metacarpal bones. So in between only you get the mid-palmar space in that area, and you get the other three lumbricals, second, third, and fourth lumbricals lie in the mid-palmar space. Okay, I think that is clear. So this diagram I could not put the reference. It's from Richard Snell. Okay, clinical anatomy by regions, Richard Snell. Okay. So this is a diagram I developed from the same thing to show you a point here. Now you get your thenar space here and your mid-palmar space here. You get the lumbricals. You get the first lumbrical in the thenar space, as I said before, and second, third, and fourth lumbricals in the mid-palmar space. Now these lumbricals, distally, these lumbricals are attached to the extensor expansion. Okay, you get your fingers like that, they are attached to the extensor expansion. Now when the lumbricals pass from these spaces to get attached to the extensor expansion of the fingers, they pass through, especially these three, and the second, third, and fourth ones, they pass through your web spaces. Your web spaces are here. There are three web spaces. Okay. Between the index and middle and ring and the little finger, you get three web spaces. So third, fourth, and fifth, second, third, and fourth lumbricals, they pass from the mid-palmar space. When they pass into the extensor expansion, they pass through the web spaces. So infections of the web spaces can spread into the mid-palmar space through the lumbrical canals. I'll show you a different diagram later. Remember that point. Then about the different sheaths in the fingers covering the tendons, there are what are called fibrous flexor sheaths, which are actually, they form fibro-osseous tunnels, because on one side you get the fibrous tissue, on the other side you get the bone, through which these fibro-osseous tunnels you get the long flexor tendons, flexor digitorum profundus and superficialis tendons passing through. To reduce friction between this fibro-osseous tunnel and the tendon, you get synovial sheaths covering the tendons, the tendon sheaths. Okay, and this is how, if you put them in a diagram, can you switch off your mic? Yeah, be careful with your mics. Okay, now then synovial sheaths of tendons, if you remove the fibrous flexor sheaths, this is how you see the synovial sheaths covering the long flexor tendons. Now second, third, and fourth finger tendons, they have synovial sheaths which end just proximal to the metacarpophalangeal joints, so you can find out the metacarpophalangeal joints in your, now on the dorsum of the hand, it's easy to identify the level of the metacarpophalangeal joints. But if you want to find it on the palmar side, again you do the same thing, then you can find the position of the metacarpophalangeal joints. So it's somewhere here. So just proximal to it, the synovial sheaths will end. So your metacarpophalangeal joint is somewhere here. So just proximal to it, the synovial sheaths will end in the second, third, and fourth fingers. When it comes to the thumb, the synovial sheath continues into the forearm. Okay, continues into the forearm. Actually, it communicates with the forearm space, which is called space of Parona here. We'll come back to it again later. So that synovial sheath is called radial bursa. Similarly, the little finger synovial sheath, it also continues into the proximal the forearm space, space of Parona, and it is called ulnar bursa. The only difference is in the palm, the ulnar bursa actually encloses the second, third and fourth tendons as well in a common synovial sheath. Okay, and in about 50% of the cases, even though we draw them separately, these two communicate. Radial bursa and ulnar bursa communicate in about 50% of the people. And even if they don't communicate there, through the forearm space, they can communicate. Okay. Then your lumbricals, these are the lumbricals which take origin from the flexor digitorum profundus tendons. They take origin from the tendons and they are attached to the extensor expansion here at the back. Okay, expansion here at the back, and your okay, if I put the fibrous flexor sheaths, these are the fibrous flexor sheaths covering the synovial sheaths, and your aponeurosis, the palmar aponeurosis, there are 4 slips again dividing into 2 slips attached on either side of the fingers, the proximal phalanx. So this is your skin. This is your skin of the web spaces, and these are the web spaces. Okay, again, if you want to assess it on your hand, your metacarpophalangeal joints are here. If you bend it, okay, so here is your skin here. So this gap is the web space. Okay, these are web spaces. So the lumbrical canals, which gives space for lumbricals muscles to travel, actually connects the mid-palmar space here into the web spaces. So these 3 are the web spaces. Okay, so web space infections can easily spread into the mid-palmar space, therefore, or vice versa. So you just to add to it, superficial transverse metacarpal ligament will lie further superficial to all these structures like this, and the deep this is superficial. The deep transverse metacarpal ligament lies deep to all these structures. Okay, so this is I adapted from Chaurasya, I think. Very nice diagram. So I'll add them. You get the skin of the palm here. This is the palm side. This is the dorsum side. So you get the skin, then the superficial transverse metacarpal ligament just under the skin. Okay, and then between then you get the deep transverse metacarpal ligament further deep. So you get all your digital nerves and vessels and the tendon with their flexor synovial sheaths and your lumbricals and the digital slips of the palmar apon, they all lie between the deep and superficial transverse metacarpal ligaments. The only structures that are posterior to the deep transverse metacarpal ligament are the interossei and the metacarpal bones here. Interossei and the metacarpal bones. Okay, so it's a very deep one, the deep transverse metacarpal ligament. Okay. Then few things about tenosynovitis. I will not read the whole slide. It will take a long time. The point I want to raise about the tenosynovitis is that it's bacterial infection of the synovial sheaths of the fingers, usually due to penetrating wounds rather than infections spreading from the pulp spaces. Okay, so pulp space infection is a different entity. So it's usually direct penetration of the synovial sheaths will give rise to the tenosynovitis. Now all these clinical points you can remember, you can go through it later, but theoretically if you get tenosynovitis of the index finger, theoretically it spreads first into the thenar space, because the tendon synovial sheath of the index finger and the thumb lies above the thenar space. So it can rupture into the thenar space proximally. And infection of the ring finger, okay, this one will go into the mid-palmar space. But the middle finger, since the the lateral septum is attached to the third metacarpal bone, which is the metacarpal bone of the middle finger, the possibility is there for the infection to spread either into the thenar space or the mid-palmar space. Okay, because the tendon can be on either side sometimes. That is the reason, I think. So it can spread into both spaces depending on the situation. And the thumb and little finger, the infection can directly spread into the forearm space because they continue into the forearm, as I said before. Okay, the ulnar bursa and radial bursa continue into the forearm space of Parona. But from a clinical point of view, deep infections in the palm are usually not confined to any particular space. Okay, so if it spreads from index finger into the thenar space, in no time it will spread to other spaces as well. They are all connected up somewhere. Okay, so this is only a theoretical importance. Okay, so practically you can't say that it will get limited to that space. So the same thing is mentioned here. From a clinical point of view, infection of the index, middle or ring finger sheath is as disastrous as infection in the thumb or little finger sheath. Okay, so you can't say that these two are more disastrous than the others. Okay, because they directly go into the forearm space. Forearm space infection is very serious anyway. Okay, so this is your forearm space, which is called space of Parona. Its boundaries are, superficially you get the flexor digitorum profundus. I'll show you a different diagram. So you get flexor digitorum profundus here, then the flexor pollicis longus and flexor carpi ulnaris superficially. Flexor carpi ulnaris, and deep you get the Pronator quadratus. Pronator quadratus and the interosseous membrane. Okay, Pronator quadratus and the interosseous membrane. Mainly the space is here in the distal end, close to the wrist, but the infection can spread proximally. But the spread proximally, when it spread, the spread is limited by the oblique attachment of the flexor digitorum superficialis. Okay, flexor digitorum superficialis. So don't get confused between the boundaries and the limitation. Okay, even I get confused sometimes. So boundaries are these. Okay, some authors just mention flexor digitorum profundus as the superficial boundary and as deep boundary Pronator quadratus. But this is a complete list, I think. I read it from a research article. Okay, so these are the exact boundaries. Okay, what lies superficially and what lies deep. Okay, but the infection is limited by flexor digitorum superficialis proximal attachment. As you can see here, the ulnar bursa and radial bursa communicate directly with the forearm space here. Okay, but these also, if there is infection and raised pressure, they can actually drain into the infection can spread into the forearm space. Then pulp infection, pulp space infection, which is here, pulp space infection. Issue with the pulp space is that if this is your pulp, it is divided into sub-compartments transversely like that. Your digital nerves and arteries go in that direction, longitudinal direction. So if several compartments are infected, putting a transverse incision is not recommended because the infection is there in other compartments as well. And the transverse incision can actually damage your digital vessels and nerves. So you rather put a longitudinal incision so that you will cut through all the compartments, sub-compartments, and release the pressure. So that is one point that you need to remember. So you put incisions like that. Then the other point is that if you look at this, you can see that the diaphysis is supplied through the compartments. Okay, diaphysis is supplied through the compartments. If the digital nerve is compressed by pulp space infection, diaphysis is at risk of ischemic damage. On the other hand, the epiphysis is proximal to the pulp space, and pulp space infection and will not affect the blood supply of the epiphysis. It's a proximal supply. So that's the clinical point. Other point that anyway you will have to treat it. Okay. Then about lumbricals and interossei. Lumbricals are attached to the extens expansion, as I said before, passing through the lumbrical canals. They take origin from the flexor digitorum profundus, of course, from the four tendons going into index, middle, ring and little fingers, and they are attached to the extens expansion. Technically their action is to extend the interphalangeal joints. But I personally feel that since it is attached to a structure at the back of the finger, when they contract, they will definitely flex the metacarpophalangeal joints as well. So when I discuss lumbricals and interossei, I take them together and I say that they flex the metacarpophalangeal joint and extend the interphalangeal joint. Okay, but textbooks sometimes they only say that they extend the interphalangeal joints, which is not the case. Practically, they will flex the metacarpophalangeal joints as well. Then the lateral two lumbricals are supplied by the median nerve, and the medial two lumbricals are supplied by the ulnar nerve, going by the nerve supply of the flexor digitorum profundus muscle. Medial half supplied by the ulnar nerve, lateral half supplied by the median nerve. Okay. So this is again a very nice specimen. You can see a beautiful lumbrical here attached to the extensor expansion. Okay, and you can see faintly, you can see an interosseous also there. So this one shows both lumbrical and interosseous. This is the extensor expansion at the back of the finger. This is lumbrical going into the middle finger, I suppose, and this is the interosseous, which is attached to the base of the proximal phalanx as well as the extensor expansion, both. Okay, so they are attached to the extensor expansion as well as the proximal phalanx, interossei, and they flex the metacarpophalangeal joint and extend the interphalangeal joint. So this is the point where I mentioned you take the lumbricals and interossei together and say that their action is to flex the metacarpophalangeal joint and extend the interphalangeal joints, which is very easy for your descriptions. Okay, all interossei are supplied by the deep branch of the ulnar nerve. Okay, so all interossei are supplied by the deep branch of the ulnar nerve, unlike lumbricals, which are supplied by both median and ulnar nerves. And usually the ulnar nerve ends by supplying the adductor pollicis muscle, but sometimes it will extend into the thenar muscles as well, the supply, I mean. Then when it comes to the interossei, you have palmar interossei as well as dorsal interossei. Usually there are three, and the palmar interossei, you remember their action as PAD, palmar adduction. Palmar interossei, they adduct the fingers. Therefore, you usually get palmar interossei for the index finger, ring finger, and little finger, because you cannot adduct the middle finger further. It's in the midline. Only three palmar interossei, but sometimes some people will have a fourth interosseous. Okay, on top of adductor pollicis, you can have another interosseous to adduct the thumb. Okay, even though it's not very economical, you can have. Okay, so usually it's three palmar interossei. You can have a fourth one attached to the thumb. Okay, then dorsal interossei, the function is remembered as DAB, dorsal abduction. So usually you get 4 dorsal interossei, 1 to the index finger, then 2 to the middle finger, and 1 to the ring finger. Okay, 1 to the ring finger. You don't get dorsal interossei to thumb or the little finger. They have their own abductors. So between the two origins of this first dorsal interosseous, you get actually the radial artery entering the palm, passing through the anatomical snuff box. Okay. Okay, same point. Now, when it comes to the anatomical snuff box, as I said before, the boundaries, in the anatomical position, the lateral border is formed by the abductor pollicis longus and the extensor pollicis brevis tendons, which are extensor muscles, and the medial boundary is formed by the extensor pollicis longus tendon, and the roof is by the deep fascia, and the floor is formed by the radial styloid, scaphoid, trapezium, and the base of the thumb. There are 4 bony points. Since the scaphoid is there, when you get scaphoid fracture, if you press the anatomical snuff box here, you get tenderness. Okay, scaphoid tenderness can be detected there because it forms the floor, one of the bones that form the floor. And the radial artery, after giving the superficial branch to the superficial palmar arch, the artery continues through the anatomical snuff box and passes deep to the first dorsal interosseous to enter the palm to form the deep palmar arch. Then superficially on the roof here, on the roof of the anatomical snuff box, you can get branches of the superficial radial artery. superficial branch of the radial artery can be there, which are coming to supply the skin of that area. Then you can also have the cephalic vein starting from the dorsal venous arch in that area. Okay. Okay, this is to show you the radial artery entering the palm again. Few points about the ulnar claw hand. Ulnar claw hand. Now you can have full claw hand. You can have full claw hand, like in Walkman's ischemic contracture. If you get typical Walkman's ischemic contracture, you get a full claw hand as well as flexing of the wrist joint like this. Then you get lower root injuries. You get you get full claw hand. C8 and T1 gone, you get full claw hand. Wrist will not be flexed, but you get full claw hand. Here it's ulnar claw hand. Ulnar claw hand, because the median nerve is intact, you get ulnar claw hand. Now the reason is this: when the ulnar nerve is damaged, all interossei are paralyzed. All interossei are paralyzed, and the medial two lumbricals are paralyzed. The action of lumbricals and interossei are to flex the metacarpophalangeal joints and extend the interphalangeal joints. Now, by doing that, by flexing the metacarpophalangeal joints, lumbricals and interossei oppose the action of extensors of the forearm. By extending the interphalangeal joints, they oppose the action of long flexors of the forearm. So when the ulnar nerve is gone, because of the lack of lumbricals to and the interossei both to the ring finger and little finger, you get flexion of the ring and little finger by the flexors and extension of the metacarpophalangeal joint. The flexion of interphalangeal joints by flexors and the extension of metacarpophalangeal joints by the extensors. So that's what has happened here. Ulnar claw hand. So the index finger and thumb are less affected because they have their lumbricals intact. Okay. Then the reason for ulnar paradox. Now the paradox means you see something that you don't expect to see. So if a nerve is damaged, usually if a nerve is damaged proximally, compared to its distal damage, proximal damage should cause more deformity than the distal damage. That is the usual thing expected. But in ulnar claw hand, if the damage to the ulnar nerve is proximal rather than distal, the clawing of the hand is less, the deformity is less. The functional loss would be more, but the deformity is less. The reason is that now the medial half of the flexor digitorum profundus is also paralyzed. Medial half of the flexor digitorum profundus is also gone because the damage is proximal. So this flexion is less now, because that is due to the unopposed action of flexor digitorum profundus. When that is gone, the flexion is less, so you get less clawing. Now you get less clawing. So that is the paradox that you notice here. Okay, ulnar paradox. Median nerve damage at the elbow. Now, median nerve is not like ulnar nerve. It supplies more structures than the ulnar nerve. So you get a lot of things lost due to median nerve damage at the elbow. Now, when the median nerve is damaged at the elbow, you get pronator muscles of the forearm paralyzed. So you get the forearm like in the anatomical position, it's supinated. When the forearm is kept in the supinated position, then the long flexors of the wrist and fingers are paralyzed, except for flexor carpi ulnaris and medial half of flexor digitorum profundus. That is understood. Then the wrist flexion is weak and is accompanied by adduction, because now the flexor carpi ulnaris it's not only a flexor of the wrist, it's an adductor of the wrist. Now flexor carpi radialis is not only a flexor, it's an abductor of the wrist. Now that is gone. Okay, because of that, when you flex, you get slight adduction. Then no flexion is possible at the interphalangeal joints of the index and middle fingers, because the flexor digitorum profundus, the lateral half is gone, as well as the other, the flexor digitorum superficialis is totally gone, because the median nerve is gone. So weak flexion of the metacarpophalangeal joints of the index and middle fingers by the interossei can be there. Okay, but when tried to make a fist, the index finger and to a lesser extent the middle finger. They tend to remain straight, which is called the Benediction sign. So this is the Benediction sign. So this is the normal one. So this is with the median nerve paralysis. Okay. So this is due to this reason it's overlapping. Now you get the flexor digitorum profundus muscle. You say that the lateral half is supplied by the median nerve, medial half is supplied by the ulnar nerve. When it comes to the middle finger, the area of the muscle that gives rise to the tendon going to the middle finger can have some overlap of supply. So it's not even though we draw a line here, rather than the median nerve, some ulnar nerve supply also can be there. Okay, so it's shedding of supply to the other side. Okay, because of that you get the middle finger less affected in Benediction sign compared to index finger. Remember that point. Then the flexion of interphalangeal joint of the thumb is also lost. Okay, this is also lost because the flexor pollicis longus is gone. Okay, and since the flexor pollicis longus gone and your abductor pollicis brevis is gone here, okay, the unopposed action of adductor pollicis will adduct the thumb, and the flexors are gone here, flexor pollicis, and the extensors here at the back will extend the thumb. So the thumb will be extended and adducted. Thumb will be, I'll show you. Thumb will be the thumb will be can't show. Thumb will be extended and adducted like this. Okay, extended and adducted. So this is how you see it. Thumb is extended and adducted. You cannot oppose the thumb to the fingers because the opponent's pollicis and things are gone here. Okay, so this is called ape hand. So it's the hand. It's the hand of an ape. Like, okay, so you cannot oppose with the fingers and it's kept on the side, extended and adducted, because the thenar muscles are affected here. Adductor pollicis is not affected. I think it's clear to you.